Hello everyone. I am Docsaab and welcome to my presentation on understanding breastfeeding challenges. Today we will navigate the various difficulties, special circumstances and contraindication related to breastfeeding. Our goal is to provide a comprehensive overview to better support mothers and infants on their breastfeeding journey. Let's begin by discussing some common difficulties encountered during breastfeeding. These challenges often arise but can be effectively managed with the right knowledge and support. Starting with inverted or flat nipples, contrary to common myths, the shape and size of the nipple matter less than its protractility, the ability to extend when stimulated. A flat nipple protrudes when you gently pinch the base, while an inverted or retracted one pulls inward. The good news is, flat nipples rarely cause problems because babies suckle the areola and breast tissue, not just the nipple tip. For inverted nipples, antenatal intervention like nipple cells are ineffective and can even cause discomfort. Management truly begins at delivery. Build the mother's confidence by reassuring her that patience and preservations pay off. Start with the skin to skin contact immediately after birth to promote bonding and milk letdown. Help her position the baby in various holds like the cross cradle and use techniques to evert the nipple such as the pinch and roll method. For a persistent retraction, the Kesari method, using a syringe to gently draw out the nipple, can be game changer in the first few days, gradually resolving the issue as the baby nurses. Now, sore nipples, which impacts about 70% of breastfeeding mothers in the first week. Causes are multifaceted: poor latch leading to friction, the baby sucking only the nipple tip instead of compressing the areola, overwashing with soap that strips natural oils, or fungal infections like candidiasis. Poor attachment look like this. The baby's mouth covers only the nipple, causing pinching, versus good attachment where the mouth flanges out and covers most of the areola. Treatment emphasizes continuation with the corrections. Do not stop breastfeeding, as that can worsen supply. Expose nipples to air between feeds for healing, and apply a few drops of hind milk post nursing. It's antimicrobial and moisturizing. Avoid frequent washing. Simple water rinses suffice. For fungal issues, apply topical antifungals like nystatin to the nipple and baby's mouth. The modified cradle position, mother sitting, cradling the baby with the hand supporting head and neck, often resolves positioning woos. If pain persists beyond a week, rule out vasospasm or thrush. Seek a lactation consultation early. Early fixes prevent escalation to mastitis. Moving on, let's look at breast engorgement and abscesses, two conditions that can cause significant discomfort. Breast engorgement hits around days 3 to 4 postpartum as mature milk comes in, causing breast to become swollen, hard, and tender with the areola stretched thin, making latching difficult. Causes: delay breastfeeding initiation due to C-section or separation, poor attachment leading to incomplete emptying, overabundant supply, infrequent feeds, or self-imposed time limits on nursing. Prevention is proactive. Offer support to all mothers right after delivery, ensure deep latch from the start, and promote on demand unrestricted feeding. Aim for 8 to 12 times in 24 hours. For treatment, apply warm compresses for no more than 15 minutes to promote letdown without overstimulating, followed by gentle massage toward the nipple. Paracetamol eases pain, but the cornerstone is frequent nursing or pumping to drain the breast. If severe, hand express just enough to soften the areola for better latch. Think reverse pressure softening with fingers to push fluid back. Untreated engorgement risk mastitis, so monitor closely. A breast abscess is a red flag: high fever, localized throbbing pain, warm red overlying skin, and possibly pus. It's often a complication of untreated mastitis. Management requires urgent medical care, incision and drainage under local anesthesia, plus IV or oral antibiotics like diclofloxacillin. Crucially, continue breastfeeding from the unaffected breast. Pump the infected site to maintain supply but discard that milk until cleared. Finally, other potential issues like mastitis, inflammation from milk statis or bacteria causing a flu-like symptoms, Plugged ducts, tender lumps from blocked pores, and persistent pain warrant attention. Mastitis treatment mirrors abscesses but start with antibiotics and continue nursing. For plugs, use warm showers, vibration, and frequent feeds. Pain beyond initial soreness, investigate low supply, hyperlactation, or infection. One of the most common concerns for new mother is whether they are producing enough milk. Let's discuss how to identify, understand, and address this. Indicators of insufficient milk supply include a baby showing low energy, appearing hungry after most feedings, or having nursing sessions that are either very short or extremely long, fewer than 6 wet diapers daily after day 5, poor weight gain. A low output when pumping might also suggest an issue, though this should be assessed alongside other signs. A poor latch can prevent the baby from effectively draining milk regardless of supply. Conversely, signs of adequate milk intake include audible swallowing during feeds, indicating a proper milk letdown and larger mouthfuls of milk. Causes can be categorized into maternal and practice related factors. Maternal factors include smoking, alcohol consumption, certain medications or herbs, hormonal birth control, previous surgeries, hormonal imbalances, stress, pregnancy, and even the return of menstrual period. Intrinsic factors related to glandular tissue development can also play a role. Practice related causes involve infrequent breastfeeding, poor positioning or attachment, short or hurried feeds, and breast engorgement or mastitis. Nipple shields and pacifier can also inadvertently reduce supply. Treatment strategies encompass behavioral changes, lifestyle adjustment, and medical intervention. Behavioral strategies include more frequent feeds, especially at night, ensuring proper latch, managing painful conditions, and using back massage to stimulate lactation. Mothers can gently massage breast before and during feeds, use breast compression, and practice relaxation techniques. Lifestyle recommendations include resting when the baby rests, maintaining a balanced high protein diet, and ensuring adequate hydration. Medical intervention might involve lactation consultation for guidance and pumping to increase supply. Some medication known as galactogogues like domperidone may be prescribed cautiously. Herbal remedies such as blessed thistle and fenugreek are also used, though their scientific efficacy is not fully proven. Breastfeeding can present unique challenges and require specific adaptation in certain situations. Let's explore some of these special circumstances. For working mothers, the recommendation is to exclusively breastfeed for 6 months. Mothers can prepare by taking breastfeeding classes, joining support groups, and discussing their plans with their employer before maternity leave. It's crucial to practice pumping or hand expression and build a reserve of frozen breast milk. Baby should also be introduced to bottle with express milk before the mother returns to work. Employers are legally obligated to provide a reasonable break times for milk expression for 1 year post-birth, along with a clean private space for this purpose. Express milk can be stored at room temperature for 4 to 6 hours, in the refrigerator for 4 days, and in the freezer for about 6 months. After a cesarean delivery, early initiation of breastfeeding is a key, ideally within 1 hour of birth. Helping the mother find a comfortable position is paramount. On the first day, she may find the supine position most comfortable. By the second day, the side lying position is often preferred, and from day 3 onwards, she can usually transition to a sitting position. Continuing with the special circumstances, let's consider infants with special medical conditions. For infants with cleft lip or palate, individual evaluation is essential, and parents should be counseled on the likelihood of breastfeeding success. Challenges can include difficulty with latching and sputtering, and feeds may take longer. If direct breastfeeding isn't feasible, express breast milk can be given via cup or spoon. A semi-upright position is recommended to minimize nasal regurgitation and reflux. Specific techniques like the football position for unilateral cleft lip and the dancer's hand position for support can be helpful. Early pumping is encouraged to establish and maintain milk supply, and lactation consultation are vital resources. Hypotonic infants who have low muscle tone also require tailored support. Breastfeeding should begin once the infant is stable, focusing on skin to skin contact and closely monitoring their latch, position, and suck. If direct breastfeeding is difficult, alternative feeding methods like the cups, spoons, or orogastric feeding may be used. Regular monitoring of weight gain is critical. Breastfeeding is particularly important for these infants, such as those with Down syndrome, as it helps reduce their increased susceptibility to infections and supports developmental progress. Special attention should be paid to signs of quiet starvation or dehydration, and weight loss should be closely tracked. Feeding preterm and very low birth weight neonates require a specialized care due to their delicate physiology and rapid development needs. In terms of feeding modes, enteral feeding should be initiated as soon as medically appropriate, ideally within 24 hours of birth, starting with the minimal amounts. Standardized feeding protocols are crucial to reduce complications like necrotizing enterocolitis. For extremely low birth weight infants, parenteral nutrition is often necessary due to gastrointestinal immaturity, providing essential protein and glucose. For milk choices, the mother's own milk is always the first choice, followed by pasteurized donor milk or preterm formula. However, unfortified human milk alone is usually insufficient for very low birth weight infants necessitating fortification. Nutritional supplementation is extensive for these fragile infants. Fortification of human milk is recommended once they reach a certain feed volume, typically with special fortifiers to boost calorie and protein intake. Post-discharge formula or enriched formula also plays a role in supporting growth. Micronutrients are critical. Multivitamins, calcium, phosphorus, and iron are routinely supplemented. Specifically, enteral iron supplementation is recommended from 2 weeks until 6 months for human milk fed preterm infants. Vitamin D supplementation is also considered, and for extremely low birth weight infants, vitamin is often given to help prevent chronic lung disease. Regular monitoring of the newborn's growth is essential to ensure these interventions are effective. Finally, it's important to understand this situation where breastfeeding is either absolutely contraindicated or requires temporary avoidance or modification. These are certain absolute maternal contraindications. These include mother using illicit drugs, those infected with human T cell lymphotropic virus type 1 or 2, and active Ebola virus infection. While previously contraindicated, mothers with undetectable HIV viral loads are now sometimes advised that breastfeeding may be an option, but this must be individually assessed with the healthcare providers. Temporary maternal contraindication and modification are most common. If a mother has untreated brucellosis or is on medications like anti-cancer or radioactive compounds, she should be temporarily avoid breastfeeding or her express milk. If she has herpes simplex virus lesions on the breast or active untreated sputum positive tuberculosis, direct breastfeeding should be avoided, but express milk can often be given. For a tuberculosis, direct breastfeeding can resume after 2 weeks of treatment and confirm non-infectiousness. Mother with hepatitis C who have cracked or bleeding nipples should temporarily stop breastfeeding until nipples heal. For infants, there are also absolute infant contraindications. These include classic galactosemia, maple syrup urine disease, and phenylketonuria. These are rare metabolic disorders that prevent the infant from processing certain components of milk requiring specialized formulas. Finally, specific medications requiring avoidance or suspension by the mother include amphetamines, chemotherapy agents, ergotamines, statins, and certain antiretroviral medications. Some opioids like codeine, tramadol, meperidine, and oxycodone are also advised against due to potential risk to the infant. Additionally, medication that can suppress milk production, such as certain estrogens, high-dose oral contraceptives, and bromocriptine, should be noted. Always consult with a healthcare provider regarding medication Thank you for your attention, guys. If you have any further questions, please feel free to reach out to me via comments or DM me on Instagram. And please like, share, and subscribe to the Docsaab's Diary